You know that feeling in your stomach when you see a name on the schedule for an emergency exam and you just know before you even open the chart what it is? It's a patient that's coming back in because that class 5 composite on number 20 that you just recently placed has popped off again. We've all been there. Non-carious cervical lesions are arguably the most frustrating restorations in everyday practice. You do your best, you isolate, you bond, you polish, and yet the retention rates are historically terrible. We start blaming the patient. We say they're brushing too hard. We say they have a heavy occlusion, or we say the flexure of the tooth is popping the filling out. And while those things might play a role, the elephant in the room is the substrate itself, sclerotic dentin. We're taught in dental school that dentin bonding is predictable. We rely on that hybrid layer. We rely on resin tags infiltrating the tubules. But when you look at the glassy, shiny, dark yellow lesion at the gum line, you're not looking at normal dentin. You're looking at a hostile surface that rejects standard bonding protocols. This leads to the massive clinical debate that we are settling today. Can you actually bond to sclerotic dentin? Should you etch it, or will that cause sensitivity? Do you need to roughen it, or is that destructive? Should you use a dedicated self-etch primer, or is good old phosphoric acid still the king? There's a lot of noise out there telling you that the newest universal adhesive in a bottle is a magic wand that works on every surface. And I'm here to tell you the literature disagrees. Today we are going to look at the highest level evidence, meta-analyses, and systemic reviews from the last decade to construct a bulletproof protocol for sclerotic dentin. We're going to stop guessing and start following the biology. Now, before we get into the specific papers, we have to understand the biological battlefield. So why is sclerotic dentin so difficult? In a healthy tooth, dentin is permeable. It's full of open tubules containing fluid and odontoblastic processes. When we etch normal dentin, we clear the smear layer, we open the tubules and expose a mesh of collagen fibrils. Our adhesive flows into those tubules and around that collagen, and it creates a hybrid layer. And that's how we get high bond strengths. Sclerotic dentin is completely different. It's a physiological defense mechanism in response to chronic trauma, whether that is abrasion, erosion, or abfraction. The tooth tries to protect the pulp. It lays down minerals into the tubules, effectively blocking them. This process creates a hypermineralized surface layer that is much harder and more acid resistant than normal dentin. If you look at it under a scanning electron microscope, it does not look like a sponge. It actually looks like a solid sheet of glass. Now, this presents two major problems. First, there are no open tubules for resin tags to form. Second, the acid in your self-etch bottle is often too weak to dissolve that hypermineralized layer, meaning that you never even reach the underlying collagen. You're essentially trying to stick tape to a dusty window without cleaning it first. And this brings us to our first major piece of evidence, and this is a big one. In 2018, the Journal of Dentistry published a massive meta-analysis by Loquercio and colleagues, and this is one of those anchor studies that you probably should know. They looked at 26 clinical trials to evaluate the retention of cervical restorations. They were specifically comparing bonding to sclerotic dentin versus normal dentin. They were testing different surface treatments, and the data was super clear. Across all adhesive types, whether the 3-step gold standards or modern universals, bonding to sclerotic dentin resulted in a significantly lower retention rate compared to normal dentin. However, Loquercio's team found a variable that actually changed the game. They found that when a dentist performed mechanical roughening of the surface before bonding, the risk of failure dropped a ton. The relative risk of failure was cut nearly in half. So this directly challenges the minimal intervention mindset where we think that we should just clean the tooth and bond. The literature says that if you leave that shiny, sclerotic surface intact, you are setting yourself up for failure. You have to disrupt it. This concept is further supported by a systematic review from Martinez in the Journal of Dentistry in 2014. This study is crucial because it dug into the why of the failure. They looked at the chemical interaction. They found that mild spetch adhesives, which are very popular because they reduce post-op sensitivity, are the worst performers on sclerotic dentin. Their pH is simply not low enough to demineralize that hyper-hardened surface. They can't get through the glass. The study concluded that etch and rinse adhesives, or universal adhesives used in an etch and rinse mode, performed way better. You need the phosphoric acid to break through that mineral barrier. Now, I know what you're thinking. You're thinking, Ryan, if I put 37% phosphoric acid on deep dentin, I'm going to cause sensitivity. Well, that is the fear that drives us to use the self-etch systems. But remember the biology that we discussed. Sclerotic dentin has occluded tubules. It is not permeable. The fluid movement that causes sensitivity, the hydrodynamic theory, is blocked by those mineral plugs. This means that sclerotic dentin is actually much less sensitive to etching than other healthy deep dentin. So the research confirms that you can and should be much more aggressive with this specific substrate. So let's talk about the surface preparation in a little more detail. We have a study by Sakara in the Journal of Aesthetic and Restorative Dentistry from 2016, and it quantifies this. They compared bonding to sclerotic dentin that was polished versus dentin that was roughened with a diamond burr. And the results were staggering. A simple 5-second preparation with a diamond burr increased the microtensile bond strength by more than 200%. And that's not a small margin. That's the difference between a filling that lasts you 10 years and a filling lasting 10 weeks. Another study by Zhang in the Clinical Oral Investigations in 2021 looked at air abrasion. Now, we love our air abrasion units, and for good reason. They found that using air abrasion prior to universal adhesive improved retention over a 2-year period in a randomized trial. So whether you use a burr or a sandblaster, the principle is pretty similar. You must mechanically remove that hypermineralized surface layer to expose a substrate that your adhesive can actually interact with. I also want to save you some time and money by referencing what does not work. A systematic review by Martinez and others also looked at chemical pretreatments like EDTA or sodium hypochlorite. The idea was that maybe they could chemically clean the protein or chelate the calcium to improve the bond. The verdict is pretty clear also, just don't bother with it. EDTA showed no significant benefit, and sodium hypochlorite actually worsened the bond strength in many cases. Lasers like erbium YAG have shown some promise in improving wettability, but the results are not super consistent compared to the very reliable results of a simple diamond burr. So let's just put this all together now. The research is pretty definitive. Sclerotic dentin is a specific entity that requires a specific protocol. You cannot treat it like normal dentin. If you rely solely on the chemical potential of a universal adhesive, you will fail. It relies entirely on your ability to remove the sclerotic layer and to etch the underlying structure. The fear of sensitivity is not really a real thing due to the nature of the tubule occlusion. What does this mean for your procedure tomorrow morning? Here is the evidence-based clinical protocol for restoring class 5 lesions with sclerotic dentin. Step 1 is isolation. You cannot bond to anything if it's covered in gingival crevicular fluid or blood. Whether you use a rubber dam or a traction cord or a good clamp, you need a dry field. If you cannot control the moisture, none of the chemistry really matters that much. Step 2 is mechanical roughening. This is the step that most dentists skip. You need to take a fine grit diamond burr and lightly dust the surface of the lesion. You're not trying to cut a deep box, you're just trying to remove that shiny, glassy surface layer. You want to see matte dentin. Alternatively, if you have an air abrasion unit, blast it with 50 micron aluminum oxide. Step 3 is the etch. Based on the Martinez review, you need phosphoric acid here. Apply 37% phosphoric acid to the enamel margins first, then bring it onto the sclerotic dentin. Leave it for 15 seconds. And I know we preach selective etch on normal dentin, but to avoid sensitivity, but on sclerotic dentin, you need to etch the lesion itself. Rinse it off thoroughly. Step 4 is your adhesive application, and you should be using universal adhesive, but you must use it in the etch and rinse mode, which we just did. Apply the adhesive and scrub it in. I mean, really scrub it in. You want to force that chemistry into the micro porosities that you just created. Most manufacturers recommend scrubbing it for up to 20 seconds. Then, and this is crucial, is to air thin it until the solvent evaporates. You want a shiny, ripple-free layer, and then light cure it. Step 5 is the restoration. Flowable composite can be great here as a liner because it adapts well to that high C-factor geometry of a class 5, but make sure it's highly filled, flowable, or use a heated composite. Warm composite flows in a consistency similar to honey, and it adapts incredibly well to the margin and reduces your chance of voids. When you follow this protocol, roughen, etch, rinse, scrub, and cure, you're aligning your clinical hands with the biological reality. You're turning a non-retentive, hostile surface into a pretty predictable bonding substrate. You will see your retention rates go up, and you will see those emergency appointments disappear from your schedule. Let's keep working together to make dentistry fun, fulfilling, and rewarding. Subscribe so you don't miss the next strategy, and I'll see you soon.